Bismillah ar-Rahman ar-Rahim. Dear colleagues, today we will talk about a very important topic in plastic surgery, which is reconstructive surgery. Reconstructive surgery means reconstruction of defects that arise in the human body due to various causes. These defects may be in defect in structure or defect in function, or both. A defect in structure, loss of a special tissue that has led to loss of function. So it's a branch of surgery that deals with correction, restoration, and improvement in shape and appearance of the body structures that are defective, damaged, misshapen by injury, diseases, or growth, and it aims at restoration of form and function. Actually, reconstructive surgery is considered the core of plastic surgery. When we think about plastic surgery as a specialty, we'll find that it is formed of different subspecialties, including aesthetic surgery, hand surgery, burns management, craniofacial surgery, and so on. So if we have a moment of thinking about what connects all these subspecialties under one specialty, we will find that the answer comes in the reconstructive surgery. And as you will hear from other lectures, that the principles of this branch of plastic surgery is used in each and every branch of plastic surgery. So, about the conditions requiring reconstructive surgery, or in other words, the etiology of defects that arise in the human body. The etiology may be congenital due to congenital lesions or acquired lesions. The congenital lesions that require reconstruction includes cleft lip and palate, vascular anomalies, auricular deformities like prominent auricles and microtia, hypospadias, craniofacial conditions, and congenital hand anomalies. While the acquired lesions that require reconstruction includes malignant lesions, trauma, infection, burns, and miscellaneous causes. In order to plan reconstruction of a defect, one has to have an idea about the criteria of the defect, and so he has to design a special or optimum type of reconstruction. In order to have this plan, there is a concept in reconstruction which is the reconstructive ladder, or in other words, how we think about reconstruction of a defect or how we approach a defect in order to reconstruct it. It is a conceptual framework for understanding reconstructive options, because there are different options for reconstruction of several defects. We start thinking about the most simple option. If it is okay for the defect, so we go on with this option. If it is not indicated for this defect, we go for a step further in the reconstructive ladder with more complex options and so on. So this is the reconstructive ladder. As you see, the first step is the most simple, which is allowing the wound to heal by secondary intention. In other words, the surgeon only role in this type of reconstruction is to do proper dressing, and then there is direct tissue closure. Afterwards, skin graft, local tissue transfer, regional tissue transfer, and the last step and the most complex is free tissue transfer in the reconstructive ladder. If you have a defect, your reconstruction of the defect will lie in one of these steps according to the criteria of the defect and the availability of tissues used for reconstruction. About grafts and flaps, when a wound or a defect cannot be closed primarily, this is the first step in the reconstructive ladder, and the second step in the reconstructive ladder, and the secondary healing, which is the first step, would be unlikely, too slow, or suboptimal. Grafts and flaps are employed to restore normal function and or anatomy. The first and second steps in reconstructive ladder, either in dressing or primary closure, and then afterwards we go for the grafts. And when we start by grafts, we start in transplanting tissues from other areas other than the defect, which we will call the recipient site. We begin to retransplant tissues from these areas to cover the defect. In order to understand the differences and the physiology of the grafts and flaps, we have to revise ourselves with the anatomy of the skin. As you all know, the skin is one of the organs. It is formed of two layers: the epidermis, which forms about 5 to 10% of the thickness of the skin, and underneath the dermis, which forms about 90 to 95% of the thickness of the skin. That's why the dermis has a major role to play in the criteria of the skin. And embedded in this dermis, there are multiple structures like the hair follicles, the sweat glands, and the sebaceous glands. And these structures are considered as reservoirs for epithelial tissue. That's to say that when a part of the skin is damaged, and part of the dermis is left in this defect, this part of the dermis that is left will contain these reservoirs for epithelium, and these reservoirs will be stimulated in order for epithelialization and migration of this epithelium in order to cover the defect. Being an organ, it has to get its blood supply, and it is the most, being the most superficial organ in the body, it gets its blood supply from deeper surface. But this blood supply starts by a major artery that comes from underneath, from the depth, and this artery, when it approaches to the skin, it starts to divide and arborize and begin to anastomose with other arteries nearby, in order to, and they form several plexuses that give blood supply to the skin. These plexuses may be subdermal, epidermal, dermal, and dermal plexuses that gives blood supply to the skin. Skin graft. When we're speaking about transplantation of tissue, we are transplanting a piece of tissue from one place, which is called the donor site, and we transplant it to another place, which will be called the recipient site, which is the defect that we want to reconstruct. When we begin to transplant tissue, we have to think how this tissue will get its blood supply. So a graft skin graft involves taking a healthy patch of skin from one area of the body known as the donor site and using it to cover another area where the skin is missing or damaged by a defect. The piece of skin that is moved is entirely disconnected from its donor site, and requires blood vessels to grow into it when placed in the recipient site in order to get its blood supply. So a graft must have a wound bed, which is the recipient site, of healthy tissue. For example, granulation tissue, muscle, fascia, bone with intact periosteum, tendon with intact peritoneum, in order to supply this graft with blood supply, and these areas are called the recipient site. This diagram shows that the graft is originally attached to its donor site by its original blood supply, and when we harvest this graft in order to reconstruct the recipient site, we completely detach this graft from its original blood supply. So in this situation, this transplant is not having blood supply, and it will be doomed if not supplied by blood from the recipient site. This is a very important point in identification of a graft, that it gets its blood supply from the recipient site. So this is about the physiology of getting this blood supply, how this graft will get its blood supply from the recipient site. First of all, when the graft is applied to the recipient site, this recipient site has to be vascular, like we said, in order to supply this newcomer with blood supply. In the first 48 hours, the graft gets nutrients by plasmatic imbibition, or in other words, evaporation of nutrients of plasma from the recipient site to the graft. After the completion of these 48 hours, new blood vessels are formed in both directions, either from the recipient site to the graft or from the graft to the recipient site, which is called the stage of enceculation. And then these new blood vessels formed, they arborize together and anastomose together in order to form plexus of vessels underneath the graft, which is the revascularization of this graft, and then this graft will get its blood supply from its new place, which is the recipient site. So a requirement for graft survival, or in other words, they require well-vascularized bed, immobile contact between the graft and the recipient site, especially in the first week during the stage of plasmatic imbibition or enceculation, low bacterial count at the site in order to guard against collection of discharge underneath the graft, which will separate the graft from the recipient site, and of course good general condition of the patient. There are several types of skin graft. It depends upon what amount of tissue we harvest from the skin. If we are in all skin grafts, the epidermis and the dermis are all harvested for the graft, but the different types of skin graft depends upon the amount of dermis that is harvested with the graft. So if we don't harvest all the dermis with the graft, we take epidermis and part of the dermis, leaving behind another part of the dermis in the donor site. This is called a split thickness skin graft. And if we harvest the whole epidermis and the whole dermis with the graft, this is called a full thickness skin graft. So, if we think about the donor site of the split thickness skin graft, we have left behind a piece of dermis. This piece of dermis, like we said before, contains sebaceous glands, sweat glands, and this means that the donor site will heal spontaneously by epithelialization from these structures. While in the full thickness skin graft, we harvest the whole dermis, so there are no epithelial reservoirs to help epithelialization of the donor sites. That's why the donor site of the full thickness skin graft has to be closed directly. There are several points for comparison of the skin graft of the different types of skin graft. The split thickness skin graft can be called Tirsch graft after the scientist who first described it, and the full thickness skin graft can be called the wolf graft after the scientist who first described it. And like we said, there is difference between both in the thickness. The donor site of the split thickness skin graft cannot be closed primarily. It has to heal with secondary intention. This means that there is no limit for the donor site of the split thickness skin graft. I can harvest a split thickness skin graft from almost everywhere in the body. And the full thickness skin graft donor site has to be closed primarily, and this means that there are limited donor sites in the body that we can harvest a full thickness skin graft from, like for example the groin, the supraclavicular area, and so on. For harvesting technique of the split thickness skin graft, the split thickness skin graft can be harvested by a skin grafting knife or a skin dermatome, a skin grafting knife, and this is the technique of harvesting this skin graft. And this is the donor site of the skin graft. And if you look at the donor site, you can resemble it to a dermal burn, because actually the epidermis was harvested and part of the dermis is left behind, and this will heal spontaneously by dressing. While in the wolf graft, the harvesting technique, it's harvested by the scalpel, like in this lady suffering from basal cell carcinoma, and the full thickness skin graft was harvested from the post-auricular skin, and it was applied to the recipient site. Of course, there are several advantages of the split thickness skin graft. It's technically easier, the graft take is better, and the donor area heals spontaneously, and the donor areas are unlimited for the split thickness skin graft. While in the full thickness skin graft, the advantages of which are the color match is very good, because we harvest the whole dermis, and like we said before, the dermis is responsible for the criteria of the skin. There is no contracture in relation relatively to the split thickness skin graft, and the sensation and function of sebaceous glands and hair follicles are retained better, they are not retained fully, but are retained better than the split thickness skin graft. As for the disadvantages of the split thickness skin graft, they doesn't resemble normal skin, so they lead to unpleasant scar, can lead to more contracture and least resistance to trauma. For the full thickness skin graft, it's very limited in size, so it's used for smaller areas, and it has limited donor sites and requires more optimal condition for survival than the split thickness skin graft. The split thickness skin graft is indicated in immediate coverage of clean soft tissue defects, immediate coverage of burn defects, and reduced fluid loss to reduce fluid loss from the wounds, prevention of scar contraction and enhanced cosmesis and superficial wounds, and reconstruction of donor sites of some flaps, like we'll see later. And for the full thickness skin graft, they are indicated in small facial defects, some types of finger defects, reconstruction of donor sites of some flaps. These are examples of, this is an example of split thickness skin graft, a road traffic accident with crushed foot and loss of skin on the dorsum of the foot. This was not amenable for reconstruction immediately, so dressing was done until formation of healthy granulation tissue, like we see here. This is healthy granulation tissue formed on the dorsum, and then a split thickness skin graft was harvested from the thigh and applied for the recipient site in the foot in order to reconstruct it. And if we look at this split thickness skin graft, we will find that several holes are made in this graft. These holes, in order to allow for fluid to come out from underneath the graft, in order to keep the graft adherent to the recipient site. And this is the final result after 6 months. Like we see here, it is not optimal in the aesthetic appearance. It is hyperpigmented and will have more contracture than other options for reconstruction, but this was the available option for reconstruction of this defect. Another example for split thickness skin graft, a gentleman suffering from basal cell carcinoma in the scalp, and it was excised with safety margin, and the bed was found to be covered by periosteum, so a split thickness skin graft was applied for reconstruction of this defect. This gentleman suffered from basal cell carcinoma on the side wall of the nose, excision again with safety margin, and the bed was covered by healthy tissue that can accept a graft. Because this is in the face, so we prefer a full thickness skin graft than to split thickness skin graft in order to give better cosmetic result. So a full thickness skin graft was harvested from the post-auricular skin, and it was used for reconstruction of this defect, and this is the appearance after 6 months. There are different types of grafts. We've been speaking about skin graft. So there are different classification of skin graft. First, if we are the relation between the donor site and the recipient site in which individual. So if we have the donor site of the skin graft and the recipient site in the same individual, the graft in this situation is called autograft. If we have the donor site of the graft in one individual and the recipient site in his monozygotic twin, this graft is called isograft. Sometimes we harvest a graft from one human being and transfer it to another human being that is not his monozygotic twin, and in this situation it is called allograft or homograft. They were used more in the past. They are not used nowadays much. They were used for extensive cases of burns, so you can get skin from other individual and cover this extensive burn for in another individual in order to optimize the general condition of the patients, because if we all know that this graft, if they are not HLA matched together, they will not be accepted or will be rejected later on due to immunological process. And sometimes there is skin graft harvested from animals, especially pigs, and transferred to human beings. We have been speaking about skin graft, but there are other tissues that can be harvested as grafts, like nerves, fat, tendon, cartilages, bones, and if we have more than one type of tissue in the graft, this is called the composite graft. Now we have been speaking about the graft or transplantation of a graft when the wound condition is optimal or the recipient site has vascular bed. But what is the condition if the recipient site has no vascular bed? That's to say, like exposed bone without periosteum, exposed tendons, and so on. So I cannot use a graft for reconstruction of these defects because the recipient site will not be able to supply this graft with the blood supply. So we have to think about another transplantation of other tissues that is dependent in its blood supply on the donor site rather than the recipient site, and this is the main difference between flaps and grafts. So the graft is dependent in its blood supply on the recipient site. The flap is dependent in its blood supply on the donor site, so it doesn't require a vascular bed in the recipient site. Flaps are tissues transferred with intact vascular supply to the recipient site. They survive through this blood supply and are not dependent on the wound bed. And the flap harvest leaves donor site that will need to be closed. The flap leaves a donor site which is a defect. We have a donor site that we harvested a flap from, so we leave behind in the donor site a defect that has to be reconstructed. The indications of the flaps, there are several indications, like we said, exposed bone, cartilage, or in other words, avascular beds, to cover an area with poor vascularity, vascular, but it has a very poor vascularity. When we have a full thickness loss of tissue, like for example in the lid, nose, cheek, lip, and to cover bony prominences, for cosmetic reasons in the face, because the flap give a better cosmetic result than the graft, and when later operations are needed in the recipient site, for example if we have a hand injury and there is a defect in this hand, and this defect contains is formed of skin, tendons, for example, and we have to reconstruct this defect, and we know that later on we will need to open again in this reconstruction in order to reconstruct other tissues that are damaged. like the tendons, so we have to use flaps in this condition. And these are several examples of what we have spoken about. This defect has an exposed bone without periosteum. I cannot apply a graft here, so I have to reconstruct it with a flap. This is an ulcer, a post-irradiation ulcer on irradiated skin. So this bed has a poor vascularity. I cannot apply a skin graft here because it will not get its blood supply from this poorly vascular bed. So I'll have to apply a flap. Full thickness loss of the lip following squamous cell carcinoma excision has to be reconstructed with a flap. For better cosmetic, this defect can be reconstructed by a graft, but we sometimes choose to reconstruct it with a flap to give a better cosmetic result, especially in the face, and if later operations are needed, like we're speaking about tendon reconstruction later on. Now we come for an important point, which is classification of flaps. When we want to classify flaps, we have to think that there are several classifications of flaps, and a single flap will fall under every and each classification. That's to say, if we think about the groin flap, there is something called groin flap. If you want to classify this groin flap according to composition, in other words, what tissues are forming this groin flap, so the groin flap is formed of skin, subcutaneous tissue, and fascia. This means that this flap is fasciocutaneous flap according to composition. If we think about this flap according to vascular supply, how did it get its blood supply, you will find that this groin flap is dependent on the superficial circumflex iliac artery in getting its blood supply, so it is something called axial pattern flap according to vascularity. And if this groin flap is used for hand reconstruction, sometimes we can use groin flap for hand reconstruction. This means that the donor site in the trunk and the recipient site is in a remote faraway area, which is the hand. So in this situation, it's called distant flap. So I can say about groin flap, it's a fasciocutaneous flap, an axial pattern flap, or a distant flap, according to which classification I want to classify this groin flap. So by composition, these flaps can be of a single component, like skin flaps, muscle flaps, bone flaps, and fascia flaps. This means that we can harvest these tissues as flap. If it is a single component, so it's called skin flap or muscle flap and so on. Sometimes, like we said before, in the groin flap, it has multiple components, and this is easier for the flap to have multiple components than the graft because it has its blood supply. Fasciocutaneous flaps, if it is formed of muscle and skin, so it is myocutaneous flap, and the most famous examples are the transverse rectus abdominis myocutaneous flap or latissimus dorsi myocutaneous flaps, which are used for breast reconstruction. Sometimes we harvest a piece of bone again with the flap, with the skin component, and so this is osteocutaneous flap. As regards the classification of flaps according to location, what do you mean by location? This means the relation between the donor site and the recipient site of the flap. So if we have the donor site and the recipient site both in the same anatomical region and they are in close vicinity to each other, so that one edge in between can be considered an edge of the donor site as well as an edge of the recipient site, in this situation we call this flap, if we harvest the flap from here to cover this is called a local flap. Like here, this defect, a flap was harvested from the same anatomical region from the face and in close vicinity to the defect, so that one edge of the defect can be considered an edge of the defect or can be considered an edge of the flap and used to reconstruct the defect. This is called local flap. What if we have this picture? The donor site and the recipient site are both in the same anatomical region and they are separated from each other by a piece of tissue that is neither considered a part of the donor site nor of the recipient site. This is called a regional flap. Like for example, in this nasal defect, this was reconstructed by a flap from the forehead. If we think about the recipient side, it is the nose. The donor side, it is the forehead. Both are in the face, but they are not in close vicinity to each other. There is intervening tissues in between that cannot be neither considered part of the recipient side nor of the donor side. So in this reconstruction, this is called a regional flap. And if you remember, when we were speaking about the groin flap, we were speaking about the groin flap that be used to reconstruct defects in the hand. So the donor side in the groin, anterior trunk, and the recipient side in the hand, in the upper limb. Both are different anatomical region, and in this situation we call this flap distant flap. Like for reconstruction of the middle finger, this is the groin flap used for reconstruction of the middle finger, and in this situation it is called a distant flap. We can classify flaps according to their vascular patterns. We have to remember the anatomy of the skin. If you remember from the first slides that we said that the skin gets its blood supply from deeper arteries that give branches, and with that anastomosis with other branches from other arteries and forms the subdermal and the dermal plexus. So we are sure that each part of the skin is covered by blood, at least through the subdermal and the dermal plexus. And this subdermal and dermal plexus has deeper original arteries. If we are thinking about the classification of the flaps, we can harvest a flap like in this diagram. This is a flap, and this flap, shall it get its blood supply? Yes, it's getting its blood supply. How it is getting its blood supply? It's getting its blood supply through the subdermal and the dermal plexus that I found here. Do I know which artery gives blood supply to this flap? No, because this subdermal and dermal plexus will be formed from this artery and another artery from here and another artery from here, so I cannot know which artery is giving its blood supply to this flap, but I know it's getting its blood supply from the dermal and subdermal plexus because I've done my incision and dissection underneath this plexus. This is called a random pattern flap. But if I deepened my incision and I go through this artery, I will cut this artery, and the blood will flow from here through this artery, and will go through the artery to the flap. So I know this flap is getting its blood supply from this artery to give the subdermal and dermal plexus of the flap its blood supply. So this is called an axial pattern flap. An axial pattern flap. If we look here, this flap, this is the flap, and this flap has no artery included inside or no artery inside underneath, but it has subdermal and dermal plexus, and this subdermal and dermal plexus gets its blood from remote artery remote from the flap. So this is a random pattern flap. This is a random pattern. This is a random pattern flap. This is an axial pattern flap where the artery is included inside the flap, and this is an axial pattern flap. Another drawing of the differences between the random pattern flap and the axial pattern flap. So the random pattern flap contains the subdermal and dermal plexus only. The axial pattern flap contains an artery, and we can resemble this to the leaf of a tree that is centered around an axis, a vascular axis that connects it to the branch, the main branch, in order to get its nutrients from the tree and do its exchange of nutrients with the tree. So this is an axial pattern flap. If we get the artery underneath the skin directly, this can be harvested as a skin flap. If the artery is lying underneath the fascia, So the fascia has to be harvested with the skin in order to keep the flap with its intact blood supply. So this is a fasciocutaneous flap. And if the artery is passing through the muscle and we have to harvest, then we have to harvest the muscle with the flap. So this is called a myocutaneous flap containing skin and muscle. So for the random pattern flap, it doesn't have a specific or named blood vessel as their blood supply. Instead, these flaps are designed based on the size of the flap base. Because of the random nature of the vascular pattern, these flaps are limited in dimension, especially in a length to base with width of ratio of 1 to 1. If designed longer than this ratio, a random blood supply often cannot support the flap. An example of random pattern flaps. Random pattern flap. This is a random pattern flap. We don't know the named artery. There is no artery included in this flap. We only depend on the subdermal and dermal plexus that is traveling through the flap length from the base of the flap. This is the base of the flap, the only attached side of the flap. So this is called a random pattern flap. While the axial pattern flap is designed with specific named vascular system that enters the base and runs along the axis, blood supply requires artery and its accompanying vein. Greater lengths are possible than with random pattern flaps, and this is an example of random pattern flap. The previous example of nasal reconstruction for regional blood supply. This is the flap harvested from the forehead, which is the paramedian forehead flap, which is based on an artery called the supratracheal and supraorbital arteries. For axial pattern flap, this is the pedicle of the flap. This is what connects the donor site to the recipient site, and it contains the artery inside. Sometimes, if we want to reconstruct this defect, this is defect in the back, and the donor side of the flap will be from here. So a flap was harvested from here, and it has to go from the recipient side to the donor side. We keep the flap only attached by its blood supply. This is the artery and vein entering inside the flap, and we pass the flap from underneath this intervening tissue. So this is a regional flap. We've passed the flap from this underneath this skin, and this is in this situation it is called an island flap. This is a pedicled flap, and this is an island flap. Another classification of flaps, we can sometimes name the flaps according to different types of nomenclature. Sometimes we can have a flap that resembles the alphabet Z, and this is called Z-plosty. And Z-plosty, if we have a linear contracture that we want to get it in another direction, we do this Z-plosty. Advancement flap. Advancement flap. This is the recipient side, and this is the donor side of the flap. And in order to get from its donor side to the recipient side, this flap will advance forward. So this is an advancement flap. Of course, the previous one, which was the Z-plosty and advancement flap, the donor side and the recipient side relation can be considered. So this flap is a local flap, VY advancement flap, which was harvested as a V, and then it advanced forwards, and the donor side and the recipient side are closed like a Y. And the transposition flap, if we have here a defect with with bone exposed without periosteum, and a flap was harvested from the adjacent tissue, and this flap is a local flap and was harvested, so keeping behind in the donor side intact periosteum which can accept a graft. I cannot apply a graft here, this is exposed bone. I can apply graft here for the donor side of the flap, and the flap was transposed and the donor side was covered. Being a defect itself has to be reconstructed, was covered by a split thickness skin graft. The last thing we want to speak about in flaps is the free flaps. Sometimes, like we said, free flaps are always axial flaps. And axial pattern flaps, they contain artery and vein. Sometimes I need for reconstruction of a defect flap, but I cannot find available tissues around to reconstruct this defect. So I harvest a defect flap from distant or a remote area or a remote recipient site, and I keep this flap attached to its artery and vein, and then I cut the artery and cut the vein from the recipient site. When I cut the artery and cut the vein, I got the flap in my hand, but it has no blood supply. I have to resupply it with blood supply again. So I get it to the donor site, and I put the flap and I anastomose the artery to the artery and another artery in the recipient site, and the vein to the vein of the flap to a vein in the recipient site, in order to restore this blood supply to this type of flap. But these types of flaps are not used commonly. They are the last step in the ladder of reconstruction, being the most complex of them, and it requires more operative time to do, and it requires several special microsurgical skills and special instruments and an operative microscope. And only an example of a free flap, this defect was reconstructed by a flap that was harvested from a remote donor site to the recipient site. And if you see here, this is the flap connected to the artery and the vein. Then we connect the artery and the vein of the flap to artery and a vein in the recipient site in order to reconstruct this defect. Of course, these types of flaps, I know they are difficult to understand. They are very easy to understand if you see them once. So please join us in our Google Classroom, and this is the link, the code for this classroom. You are most welcome to join this classroom, in order you can find there some videos explaining the different types of flaps and different techniques of harvesting skin graft. This will make things easier for you. Thank you very much.